Thank everybody for being here. Before we start this session, I'll go over some reminders that each patient's treatment and condition is unique, and the content presented in this session should not be used as a substitute for professional medical advice. And in all cases, patients and caregivers should consult their healthcare providers. And also remember that where you are on your journey of living with primary immunodeficiency may differ from that of the person sitting next to you. The severity of primary immunodeficiency can vary, and we ask that you are supportive and respectful of one another as fellow members of the IDF community. So now it's my pleasure to welcome you to the diagnosis-specific session with HLH. And this session is presented by Dr. Rebecca Marsh. Dr. Marsh is an immunologist and transplant physician treating patients with primary immune deficiencies and immune regulatory diseases at Cincinnati Children's Medical Center in Cincinnati, Ohio. Please join me in welcoming Dr. Marsh. Dr. Marsh, thank you for being with us today. The floor is all yours.
Absolutely. It's my pleasure to be here, Lorraine, and thank you to the IDF for asking me to speak today. So as Lorraine said, I'm Rebecca Marsh. I'm at Cincinnati Children's Hospital, and I'm an immunologist and transplant physician, and I specialize in HLH and some closely related disorders. And I have no disclosures other than we're going to talk about some off-label use of medications. So first of all, you in the audience, especially Michelle, know what HLH is, but it stands for Hemophagocytic Lymphohistiocytosis, which really is kind of a ridiculous name. It actually has the same number of syllables as supercalifragilisticexpialidocious. And one of my colleagues, Ashish Kumar, actually wrote a song to that about HLH. So I would encourage you to watch that sometime if you ever have the opportunity. But really, it actually has good roots in meaning. So if you break down hemophagocytic, heme means blood, and phagocytic means of a cell that eats. And you can see this beautiful picture of this macrophage on the right. And this cell has eaten red blood cells and other cells. And so hemophagocytic is really just reflecting this process that these cells get very angry and start eating other blood cells. Lymphocytosis is expansion of lymphocytes. Histiocytosis is expansion of histiocytes, and the lymphocytes and histiocytes are immune system cells. And during HLH, they really expand into an angry mob, and they start causing damage to patients' bodies. So that's where this very difficult name comes from. And really, I think of HLH, and many of us do, as a dangerous syndrome of uncontrolled systemic inflammation. And if you think about when you have just like a normal cold or a normal stomach flu, your immune system is going to have a little bit of controlled inflammation to get rid of that infection and then burn itself out. Whereas in HLH, things really do spin out of control and develop into big forest fires. Now, we're going to talk about some definitions before we really get going, just because it really gets confusing thinking about primary HLH, secondary HLH, familial HLH. There's a lot of confusion about this with patients and also as clinicians talking with other physicians. So HLH, as we just talked about, really refers to this syndrome of inflammation that we'll get a little more into in a minute. Primary HLH. So primary HLH, when we say this, we really mean genetic HLH. So patients that have genetic primary immune deficiencies or inborn errors of immunity, which feature HLH as a main part of the disease. Secondary HLH is what we sometimes refer to in patients that have HLH that don't have a genetic reason to have HLH. They may have cancer, they may have an infection, they may have an autoimmune disease. Familial HLH is really sort of a subtype of primary or genetic HLH. These are a little collection of specific disorders. So patients with defects in PRF1 or perforin, UNC13B, STX11, STXBP2. And these diseases are clustered together because they all have the same basic mechanism of disease in that some of the immune system cells, like the NK cells and T cells, can't kill other cells normally, and that's called cytotoxic function. Macrophage activation syndrome is something we're not going to spend a lot of time on today, but this is a lot of times what we call HLH that occurs in patients with rheumatic diseases or autoimmune types of diseases like systemic juvenile idiopathic arthritis, or patients with lupus, patients with autoinflammatory immune deficiencies like SAVI, and other things like that. So the HLH syndrome, so the general symptoms. Every patient is different. No two patients are ever alike, but what's really common to have in HLH are fevers, rash. You can develop a big spleen. And for those of you who don't know where your spleen is, it's sort of tucked behind your stomach, as you can see in the picture. And it's usually reasonably small, but in HLH, it can get really big, so big that it even goes past your belly button. You get low blood counts, so you can be anemic. The white blood cells can be low. The platelets can be low, which can cause bleeding problems. Patients can look yellow, which doctors call jaundice, and this is from liver problems. You can also develop liver failure. Patients can have seizures or other brain problems. So along with those clinical symptoms and signs that patients have, there are some very typical blood test markers of inflammation that doctors can use to help look for that syndrome of inflammation in patients. Patients can have high triglycerides in their blood, which are just fats. They can have a low fibrinogen, which is a clotting protein in the blood that can be low during HLH. And two things that most of you have probably heard about in your HLH journey are ferritin and soluble IL-2 receptor. And ferritin is an iron storage protein, and it goes up in the blood when you have inflammation. The soluble IL-2 receptor is really a barometer of T cell activation. When T cells get very angry and upregulated, they start shedding this soluble IL-2 receptor, and that goes up in the bloodstream, and we can measure that. There are some newer markers that we'll talk about a little bit later called IL-18 and CXCL9. IL-18 is basically an inflammatory protein that's a good marker of inflammasomes being very active. And CXCL9 is a very good marker of something called interferon gamma, which is an important part of HLH. So we're going to go through an example case to try to put some of these clinical and lab features together so that you guys understand a little more what physicians are looking for in their patients to see if they have HLH. So we have a little baby. She goes to the emergency room with 4 days of fever, not taking many bottles, not having many wet diapers, and just overall being irritable and not feeling good. The doctor examines her and notices that she looks sick, she's pale, and that she has a big spleen. When they do some lab work in the emergency room, these are the results that they get back. And what you can see, if I had a pointer, I would point them out to you, but you can see on the left that the WBC is low. That's the white blood cells, and those are low. You can see that the hemoglobin is low. You guys have probably looked at your own hemoglobins in your own labs. This patient's anemic. The hemoglobin is only 7. You'll see that the platelets are also low. They're 72. And then there are some numbers on the right, and you'll see that 3 of the liver numbers are high. So the ALT, the AST, and the bilirubin, and that's because this patient's having liver inflammation. When they start to think about HLH, because the patient has these fevers and the low blood counts and the liver inflammation, they do some of those inflammation tests. And they do a ferritin, and it's very high at 6,000, even greater than 6,000. The lab couldn't even measure it. And then the soluble IL-2 receptor level was 25,000, which is also quite high. And because of the fever and the big spleen and the low blood counts, and then the high levels of the ferritin and the elevated soluble IL-2 receptor, this patient was diagnosed with a syndrome of HLH, with the syndrome of too much inflammation. And this is just a table showing the criteria that a lot of physicians still use today to help them think about the syndrome of HLH. It's not perfect and it's a little outdated, but a lot of physicians still sort of use these criteria. So I like to include it here so that everyone can see it. So what could be the cause of HLH in this patient? And this is very important to determine. A long time ago, people would just say a patient has HLH and they must have some genetic reason to have it, and that's sort of where they would stop. But there are lots and lots of things that can cause HLH. Infections, cancers, all of the infections that I've shown here. So it's really important to figure out why a patient has too much inflammation so that you can treat it the right way. So there are too many causes of HLH to list them all. So we're going to talk about some main categories today. So cancer is an important cause of HLH. Leukemias, lymphomas are the most common cancer causes of HLH, but it can concur with a lot of others. Infections, and I cannot list all the infections that have been associated with HLH, basically practically any infection. Monoviruses are especially common, things like EBV, CMV, influenza virus, coronavirus, also fungal infections like histoplasmosis, other infections like tuberculosis, tick-borne illnesses, bacterial infections, and really anything else. Rheumatologic diseases, so things like systemic JIA, lupus. Metabolic diseases, which we're not going to talk about today, but they're important to remember. And then the genetic causes of HLH, or the primary HLH diseases that we're going to spend basically the rest of the talk talking about. And unfortunately, we don't have time, but there are other inborn errors of immunity or primary immune deficiencies that can also develop HLH, things like SCID, the George syndrome, chronic granulomatous disease, Wiskott-Aldrich syndrome. And in these diseases, it's not typically that the genetics themselves lead to the HLH. In these other immune deficiencies, typically there's a very bad infection going on that then leads to too much immune system activation and inflammation. So again, primary or genetic HLH are really the genetic diseases that cause HLH, and that's what we're going to spend the rest of the talk talking about. So what about our little patient? So this patient had a lot of workup done to try to find the cause of too much inflammation. She had a bone marrow, didn't show any cancer, had CT scans, didn't show any cancers or any infections, no big pneumonias, things like this. Didn't find any infections with a lot of blood tests. No rheumatologic or metabolic diseases were found. And so since all of those things were ruled out, physicians started to wonder if she had a genetic or primary HLH disease. So what diseases do we need to think about and test for? So this is the list that I keep in my head most of the time. There are some other diseases that can go on this list, and I tend to think about those very quickly after some of these things come back to be normal. But in familial HLH, there are 4 genes, including PRF1, UNC13D, STX11, STXBP2. There are pigmentary disorders associated with HLH, and they're listed there. XLP1 and XLP2 are associated with HLH. Patients with activating mutations in a gene called NLRC4, patients with problems with a gene called CDC42, and then some other EBV type disorders that can also be associated with HLH I tend to include in my list. So what about our little patient? So this patient was actually found to have 2 disease-causing variants in the UNC13D gene, which causes familial HLH type 3. And this is just a simple blood test that's done to look at the DNA. And as you can see in the cartoon, this is what we call an autosomal recessive immune deficiency. And what that means is that each parent has 1 good copy of the UNC13D gene that works, but they have 1 broken copy of the UNC13D gene that doesn't work. And there's a 25% chance that a child will inherit the bad copy from the mom and the bad copy from dad and be affected by HLH. So why do patients with genetic HLH diseases develop the syndrome of HLH? So in the primary HLH, genetic HLH disorders that are shown here in blue, so familial HLH and then some of the pigmentary disorders, there is a problem with the way that certain immune system cells kill viruses and cancers. And what you can see in this little bit of a complicated cartoon is there's an NK cell or a CD8 positive T cell, and these are cells that kill virus-infected cells and cancers and keep you healthy and keep you from becoming too sick with viruses or cancers. And in these cells, there are little granules or little purses. And these purses have all sorts of killing chemicals in them, essentially. And these NK cells or T cells basically dump all of their purse contents onto virus-infected cells or cancer cells, and they kill them. But in patients with these causes of HLH, that process doesn't work normally, and they can't kill the cells. All right, and these are going to go kind of quick, Lorraine. So
Okay.
in normal patients, so you have macrophages, which is a type of immune system cell, and then you have the CD8 positive T cells. And when macrophages get infected with a virus, they get unhappy, obviously, and they want to take care of this infection. They send signals and secrete cytokines, which are inflammatory proteins, to tell the T cells to kill them. The T cells listen. They say, yes, I'm going to come over and I'm going to kill you, virus-infected cell, and make my person healthy and happy again. They secrete interferon gamma. They get revved up. They start dumping all of those purses full of poisons onto the cell and kill it. Now, once that cell's gone, the CD8 positive T cells say, oh, yay, we did a great job. Now we can just go to bed and our patient's all better. And most of those T cells actually die and go away, and you're left with just a few memory T cells that then stick around to help prevent you from getting that same infection ever again. Now, in patients who have those genetic HLH diseases that we talked about, that does not happen normally. When macrophages get sick, they secrete those signals and cytokines, but then those T cells, they can't do anything. They can't kill that cell. They get really angry because they're not able to kill that virus-infected cell. They start proliferating and calling other friends. They secrete lots of other cytokines, interferon gamma. They get really angry, start to proliferate even more, and this makes the macrophages very angry as well. They start secreting more cytokines. All of the cells start proliferating and growing, and what eventually happens is you have this huge influx of all of these inflammatory cells that are angry, and you start causing damage to your own body. So you can damage your bone marrow. Cells start eating the other cells. You can damage your liver. You can damage your brain. All of these cells start doing a job that they're not supposed to be doing, and it's like a forest fire. Now, what about some of the other HLH diseases? So in XIAP deficiency, or XLP2, and in a genetic disease called NLRC4, it's not the T cells that have the problem, it's the macrophages that have the problem. So you're starting on the other end of the cycle. In these diseases, the macrophages have a protein structure called an inflammasome. And in normal people, inflammasomes are very quiet. They don't do much. Every now and then when there's an infection, they'll have a little spurt of inflammation, and then they turn off very quickly so that you don't get sick. But in patients with XLP2 or NLRC4, those inflammasomes are active all the time. And so they're always making inflammatory proteins called IL-18 and IL-1 beta. And when that's the case, just because they're always active and a little bit angry, that can sometimes then make the T cells angry. And so you can end up with HLH. And then there's also XLP1 or SAP deficiency. And this disorder is unique because it's really mostly a problem with EBV. And that's because the T cells can't kill mono-infected B cells very well. Because they can't kill those mono-infected B cells very well, the T cells get very angry, which makes the macrophages very angry. And again, you end up with HLH. And then there are other genetic diseases that we don't have time to talk about today, but I'm happy to answer any questions later. So how do you diagnose genetic HLH diseases? We don't have a lot of time to go into this today, but I'm happy to answer questions later. The short story is that genetic testing is the gold standard best test. You can do a blood test. You can take a little sample from your cheek with a little Q-tip. There are other ways to get DNA. You send this off to the lab. Depending on the turnaround time, which is anywhere from 48 hours to 6 weeks, you will get genetic test results back. Now, because sometimes the genetic tests take 4 to 6 weeks in some labs still, there are some rapid screening blood tests that have just a few day turnaround that can be helpful for patients and physicians. And for the different disorders that are listed, I've shown you the tests that are done, and I'm happy to talk about those types of tests and the types of results that you can see in patients with anyone after the talk who is affected by one of these and wants to know more about them. So we're going to spend the last half of the talk really talking about treatments for HLH, and you really are wanting to quiet or dampen that immune response and that inflammation. So as we go through some different agents, it's helpful to think about what's going wrong during HLH. And remember that we just talked about you have too many angry immune system cells. You have too many inflammatory proteins and cytokines, so things like interferon gamma, IL-1 beta, IL-18. There are others. We could talk about IL-6, TNF alpha. It doesn't matter. You have all of these proteins running around causing inflammation. When you have mono, you have these EBV-infected B cells running around that are causing a problem. And then also don't forget that in some patients, they have cancers or infections that need to be treated. So for instance, if you have tuberculosis, you need to be treated for tuberculosis. If you have lymphoma, you also need to be treated for your lymphoma. And in a lot of cases, those types of settings, the HLH will get better just with treatment of the tuberculosis or of the lymphoma. So our first selected treatment options. So steroids, this is by and large the first thing that patients with HLH get. Sometimes it's the only thing that HLH patients get. The only important thing to think about when thinking about starting steroids is that you want to be sure you've already checked for cancer. So patients should get like a bone marrow aspirate and biopsy. They might need a lymph node excisional biopsy. You want to make sure a patient doesn't have cancer before they get steroids, because steroids can partially treat and mask that cancer and make it hard to diagnose. So common steroids used in HLH are dexamethasone, methylprednisolone, and prednisone. You can take these things orally, which just means by mouth. You can also get them IV. You can even get a shot. And what the steroids do is high-dose steroids actually kill some of the immune system cells. So that's very helpful. Steroids also change the way the immune system cells are working, and so it suppresses those cytokines. Now, side effects from steroids, I'm sure a lot of you know, include things like weight gain, high blood pressure, problems with your sugar, can cause problems with thinning of the bones. So there's a lot of side effects with steroids, but they're very effective. Etoposide. So this is a chemotherapy medicine. So you receive this through an IV or a central line. Etoposide, basically, since it's a chemotherapy, kills immune system cells, just like you would give chemotherapy to someone with cancer to kill the cancer cells. We're giving chemotherapy here to kill immune system cells. And Dr. Jordan actually showed very nicely that etoposide is especially good at killing activated T cells. So this is a very good agent to use in patients with HLH. Antithymocyte globulin. Now this is not a chemotherapy. It is not an oral medicine. It's an infusion that you get through a central line or an IV. It's an antibody therapy. And when antibodies bind to cells, if it's the right kind of antibody, it can cause those cells to die through various mechanisms. And so basically, antithymocyte globulin is an antibody that's binding to immune system cells, especially the T cells, and it's causing them to die. Alemtuzumab. This is another antibody therapy, and alemtuzumab binds to lots of immune system cells. It binds to B cells, T cells, natural killer cells, some of the macrophages and monocytes. And alemtuzumab is a very potent killer of immune system cells, so this can be very effective for HLH. Now, because ATG and alemtuzumab are antibody therapies, the biggest side effects are reactions, like allergic type reactions to them, like you might see with like peanuts or shellfish and these types of allergic type responses. They also are very potent at suppressing your immune system, So we can see lots of reactivations of viral infections and other things with these two agents. Rituximab. Now, rituximab is really only useful in patients that have EBV virus or mono, because rituximab kills B cells. And the B cells are where the EBV really likes to live most. And so when you give rituximab and you get rid of those B cells, the immune system no longer has to become frustrated by not being able to kill them. And so it can be helpful in patients who have EBV HLH. It's also an antibody therapy. So again, the biggest risk with rituximab is these allergic types of reactions. Now, rituximab, since it kills the B cells, as a lot of you know, there are patients with immune deficiencies who don't have B cells, and they have to get immunoglobulin replacement. So if you get rituximab, very often you will need some immunoglobulin replacement. Ruxolitinib. Now, this is a newer medicine, only really being used these last few years. It's an oral medicine, which is nice. It suppresses lots of cytokines and cytokine signaling. It's what's called a JAK inhibitor. And it basically inhibits the way immune system cells are working, such that they can't make cytokines as well, and they also can't be stimulated by cytokines as well. The biggest side effect of ruxolitinib is bone marrow suppression, so lowering of the blood counts. So that's something we watch for if we use ruxolitinib. Emapalumab is another newer therapy. This is also an antibody therapy. It binds specifically to interferon gamma. So it's preventing interferon gamma from working and preventing interferon gamma from causing inflammation and contributing to HLH. Cyclosporin is a medicine that we don't really use a lot in primary or genetic HLH diseases because it causes a lot of side effects. In particular, it can cause seizures and something called posterior reversible encephalopathy syndrome, which is when you are having some problems in your brain that lead to seizures and other things. Also causes high blood pressure, causes funny hair growth, can damage your kidneys. So we don't typically use it, but I mention it here because there are still some patients who are treated with this, especially in rheumatologic patients. It's actually very helpful. And so I like to mention it here. And this medicine works by basically suppressing the T cells. Anakinra. So there's a lot of medicines, right? I promise we're almost done. So anakinra is a daily shot that you take, sort of like an insulin shot. It's what's called an interleukin-1 receptor antagonist. So basically it works like an antibody would work. It binds and soaks up the IL-1, which is an inflammatory cytokine. So it binds it all up and keeps it from causing trouble. It's used a lot in rheumatologic patients or autoinflammatory patients, also sometimes patients with XIEP deficiency, and sometimes patients with HLH. Tautokinig alpha is something that's only available as part of a clinical trial or clinical study. This is what's called a recombinant IL-18 binding protein. So basically, all of us make IL-18 binding protein. And so what this medicine is doing is giving you more of that, because what it wants to do is soak up all of the IL-18 that's being made and causing inflammation during HLH. So it's also functioning by inhibiting cytokines. It's an every other day shot. So how well do some of these therapies work? So dexamethasone and etoposide, you can expect about 50% of patients will have what's called a complete response, where the HLH completely gets better. Now there are a lot more patients which will have partial responses and get better, but not have it go completely away. Steroids and ATG, about 75% of patients will have a complete response. Additional patients will have partial responses or get better, but not have it go away. But then a lot of times there's a risk that the HLH will come back many weeks later. Emapalumab, the complete response rate is about 25% of patients. When you count patients who also have partial responses or improvement in their HLH, that number is much higher, in the 60 to 70% range. And then there are clinical trials right now that are open for alemtuzumab, ruxolitinib, tocilizumab, which we didn't talk about, but is an antibody therapy against IL-6, which is another inflammatory cytokine, and then tautokinig alpha. And don't forget, like I said before, if there are infections, you need to treat them. And if there's cancer, you need to treat it. So our patient received dexamethasone, etoposide, also got some intrathecal steroids and methotrexate because had some brain involvement with HLH. And then she received a bone marrow transplant and she's doing very well. Now, I'm going to spend just a couple of minutes highlighting bone marrow transplant for patients with genetic HLH. We could talk a whole hour about just this or even longer. Now, the first transplant was done in 1986, but this is sort of what was going on in 1986. Some good and terrible things. Now, bone marrow transplant for patients with genetic HLH, I'm going to give you just the highlights in 2 slides. Transplant is usually considered for many of the HLH disease patients, but not all of them. Patients with genetic HLH diseases are usually at higher risk of complications of transplant, and we use what are called reduced intensity conditioning regimens or reduced toxicity conditioning regimens for patients with HLH. And this is really sort of like, instead of drinking a tall Starbucks coffee, drinking just a Diet Coke. And so we give them sort of these Diet Coke conditioning regimens to decrease the risk of complications. However, that means that there is a higher risk of graft failure sometimes and needing a second transplant. Survival depends on a lot of factors, including age, wellness, the donor and patient HLA match, and things that we don't have time to go into today. But I wanted to share just some survival estimates because transplant's getting better all the time for patients with HLH. And the plot you can see on the left, these are called Kaplan-Meier survival curves. And what these show is the percentage of patients who are surviving over time. So on the x-axis, this is years, 1, 2, and 3 years. And then the y-axis going up and down is the number or percentage of patients who are surviving. And so what you can see is that for patients with HLH and XLP, there's about a 70% survival rate by 3 years when you look at 400 patients transplanted from 2010 to 2016. And this is lower than for patients with things like Wiskott-Aldrich syndrome, chronic granulomatous disease, which are on those other lines. The plot on the right is some very recent data from Tayfun Gungor and European colleagues. And what you can see is that even at 4 years post-transplant in 25 patients that were transplanted between 2009 and 2019, survival is greater than 90%. So that's very good. And then of course you want to think about other family members. When one child has a genetic HLH disorder, there are chances that other children will have it. I'm not going to go through this today, but if there are any folks in the audience who want to talk about this after the talk, I'd be happy to talk about your specific disease. But you really want to talk to your doctor or a genetic counselor about the risk of having disease in other family members. So in summary, the syndrome of HLH remains a serious problem, but diagnostic testing has greatly improved. There are more treatments available and more studies are being done. There are several genetic primary HLH diseases which cause HLH due to defects either in immune system killing or in those inflammasomes that are overactive. And genetic HLH diseases often, but not always, need treatment with bone marrow transplant. And that's it. And with that, I will say thank you to all of you for listening. And I'll thank Mike Jordan and Ashish Kumar, who, as always, we tend to share some slides around between us for presentations like this. And I'll leave you with my favorite Far Side cartoon. Thank you, guys.